Hello everyone, this is Dr. Sam and this video is about eye ultrasound reporting. You will learn how to write ultrasound reports regarding eye pathologies. The first report is of a normal eye ultrasound. This is the clinical indication in this example. Routine evaluation of ocular structures. Patient reports no visual complaints. Next is the procedure. A B-scan ultrasound of both eyes was performed in the axial and longitudinal planes with attention to the lens, vitreous body, retina, choroid, and optic nerve. The patient was in the supine position and the eyelids were closed with a water-based gel applied to facilitate sound wave transmission. Then you can write the findings. These are the findings in the right eye. The lens is normal in shape and position with no signs of cataract formation. Vitreous body, clear with no evidence of vitreous detachments or vitreous floaters. Retina, appropriately attached around the entire circumference with no signs of detachment or tears. Choroid and sclera, normal thickness and aquagenicity with no evidence of detachment or masses. Optic nerve, normal in appearance with no signs of swelling or increased diameter suggestive of increased intracranial pressure. Now we move on to the findings of the left eye. The lens is clear with no opacities. Vitreous body, homogeneous acoustic properties with no abnormalities detected. The retina is intact and attached with no retinal lesions or abnormalities. The choroid and sclera are also normal. The optic nerve is normal as well. And this is the impression. Normal ocular ultrasound examination of both eyes. No pathological findings were identified. The anatomical structures of the lens, vitreous body, retina, choroid, and optic nerve appear normal bilaterally. No further ultrasound evaluation is necessary at this time. This is a report for cataract. The clinical indication in this case was evaluation for suspected cataract due to reported decrease in visual acuity and difficulty with night vision. These are the findings related to the affected eye. Lens. There is evidence of increased aquagenicity within the lens consistent with the presence of a cataract. No lens dislocation was observed. Vitreous body appears clear with no signs of hemorrhage or detachment. The retina is attached with no evidence of detachment or tears. Choroid and sclera, normal appearance without signs of detachment or thickening. The optic nerve is normal in appearance with no signs of edema or increased diameter indicative of increased intracranial pressure. This is the impression. The ultrasound findings are indicative of a cataract in the affected eye, correlating with the patient's reported symptoms of decreased visual acuity and difficulty with night vision. No additional abnormalities were detected in the vitreous body, retina, choroid, or optic nerve. Referral to an ophthalmologist for further evaluation and management of the identified cataract is recommended. Potential management options may include monitoring or surgical intervention. depending on the severity of visual impairment and the patient's overall health status. This is a report of a patient with an intraocular lens implant. Clinical indication: postoperative evaluation of intraocular lens placement following cataract extraction and lens implantation surgery. The patient reports satisfactory improvement in visual acuity but experiences mild discomfort. These are the findings in the operated eye. Intraocular lens. The intraocular lens implant is visualized in situ within the capsular bag. There is no evidence of dislocation or malposition of the IOL. The acoustic characteristics of the IOL are consistent with its known material composition. Vitreous body, clear with no signs of vitreous hemorrhage or detachment. Retina is fully attached without retinal detachment or tears. The interface between the retina and the choroid appears normal. The choroid and the sclera are normal. The optic nerve is also normal. This is the impression. The B-scan ocular ultrasound findings confirm the correct placement of the intraocular lens implant within the capsular bag following cataract surgery. There are no ultrasound signs of complications related to the IOL implantation. The vitreous body, retina, choroid, and optic nerve are normal. This is a continuation of the impression. Given the positive ultrasound findings and the patient's reported improvement in visual acuity, continued routine post-operative follow-up is recommended. The mild discomfort reported by the patient may warrant further clinical evaluation to rule out any non-ultrasound detectable causes, such as mild inflammation, and to ensure optimal post-surgical recovery. This is a report for Ectopia Lentis. Clinical indication: assessment for suspected posterior dislocation of the lens due to recent severe blunt trauma to the eye, accompanied by a rapid decline in visual acuity and the perception of shadows. These are the findings. Lens: complete posterior dislocation of the lens into the vitreous cavity is observed, with the lens located behind the iris plane, indicating severe zonular disruption. The lens maintains normal echogenicity with no evidence of cataractous changes. The vitreous cavity contains moderate echogenic debris consistent with vitreous hemorrhage and disrupted lens material. No vitreoretinal detachment is detected. The retina is attached throughout the examined area with no signs of detachment or tear. However, localized areas of retinal edema are present, likely secondary to the trauma. Choroid and sclera are normal in appearance. The optic nerve shows no evidence of edema or abnormal sheath dilation. This is the impression. The ultrasound findings confirm a complete posterior dislocation of the lens into the vitreous cavity following ocular trauma with associated vitreous hemorrhage and retinal edema. The integrity of the retina, choroid, and optic nerve is maintained despite the severity of the injury. Urgent referral to an ophthalmologist specializing in vitreoretinal surgery is recommended for comprehensive evaluation and management. Surgical intervention is likely required to address the dislocated lens, clear the vitreous hemorrhage, and prevent potential complications such as retinal detachment or glaucoma. Prompt treatment is essential to optimize visual recovery and minimize long-term sequelae. Now we have a case of acute vitreous hemorrhage. Clinical indication: investigation for suspected acute vitreous hemorrhage following sudden onset of floaters and a curtain obscuring part of the visual field, with no history of trauma or known retinal conditions. These are the findings: vitreous body, diffuse, medium to high echogenicity within the vitreous cavity, indicative of acute vitreous hemorrhage. The distribution of the echogenic material suggests recent bleeding. No clear source of hemorrhage is visualized within the limits of this examination. Retina: the retina appears attached with no signs of detachment or tears. However, visualization is partially obscured by the vitreous hemorrhage. Choroid and sclera: these structures are not clearly visualized due to the overlying vitreous hemorrhage but appear intact where accessible. The optic nerve is normal, with no signs of edema or increased sheath diameter. Visualization is somewhat limited by the echogenicity of the vitreous. This is the impression. The ultrasound findings are consistent with acute vitreous hemorrhage, characterized by diffuse echogenic material within the vitreous cavity, obscuring detailed visualization of the posterior eye structures. The retina appears attached in the areas accessible through the hemorrhage. You can also write another section called Recommendations, which includes follow-ups and referrals, but this is optional. Urgent referral to a retina specialist is recommended for further evaluation, including possible fluorescein angiography or optical coherence tomography, to identify the source of the hemorrhage and to assess for any underlying retinal pathology. Management may include observation, vitrectomy, or other interventions based on the severity of the hemorrhage and the underlying cause. This is a case of chronic vitreous hemorrhage. Clinical indication: evaluation of persistent floaters and visual shadows with a history of recurrent vitreous hemorrhages in the past year. The patient has a known history of proliferative diabetic retinopathy. These are the findings: vitreous body. The vitreous cavity exhibits diffuse, low to medium echogenicity with scattered areas of higher echogenicity, suggesting organized hemorrhagic debris and possible formation of fibrous membranes. The echogenicity pattern is consistent with chronic vitreous hemorrhage. Retina: partial visualization of the retina is achieved, showing areas of traction that may be associated with proliferative diabetic retinopathy. No full-thickness retinal detachment is observed, although the assessment is limited by vitreous opacity. Choroid and sclera: these structures appear intact in the limited fields assessed. The detailed evaluation is hindered by the overlying echogenic vitreous. Optic nerve appears normal where visualized. The assessment is somewhat limited due to the echogenic material in the vitreous. This is the impression. The ultrasound findings are indicative of chronic vitreous hemorrhage characterized by diffuse echogenic material within the vitreous cavity, consistent with organized hemorrhage and possible fibrous membrane formation. There is evidence of retinal traction, likely secondary to proliferative diabetic retinopathy, which may be contributing to the recurrent hemorrhages. Recommendations: referral to a vitreoretinal specialist for further evaluation and management is strongly recommended. Potential management strategies may include pars plana vitrectomy to remove the hemorrhagic debris and address the underlying retinal pathology. Close monitoring and management of systemic factors contributing to proliferative diabetic retinopathy are also advised to prevent further episodes. This is a report of retinal detachment, clinical indication, evaluation for suspected retinal detachment following sudden onset of visual flashes, floaters, and a shadow or curtain over part of the visual field. These are the findings. Vitreous body. The vitreous cavity is clear with no evidence of echogenic opacities that would suggest vitreous hemorrhage. This finding supports the absence of concurrent vitreous hemorrhage with the retinal detachment. Retina. There is clear evidence of a retinal detachment with the detached portion of the retina demonstrating a smooth, membrane-like echogenicity. No visible tears or breaks are identified in the accessible views. Choroid and sclera. These structures appear normal without signs of detachment or pathology. The optic nerve is normal in appearance without evidence of edema or changes in the optic nerve sheath diameter. This is the impression. The ultrasound findings confirm the presence of a retinal detachment in the absence of vitreous hemorrhage or obvious retinal tears. The clarity of the vitreous body suggests that the detachment may be non-rhegmatogenous or secondary to another pathology not immediately evident on ultrasound. Recommendations: immediate referral to a vitreoretinal specialist is strongly recommended for detailed retinal examination and possible surgical intervention. The absence of vitreous hemorrhage and retinal tears may influence the choice of surgical approach and prognosis. Further diagnostic testing, including optical coherence tomography and fluorescein angiography, may be necessary to identify the underlying cause of the detachment and to guide treatment. This is a report regarding Rhegmatogenous retinal detachment, in which there is a tear in the retina. Clinical indication: evaluation for complex ocular findings following patient reports of sudden visual loss, flashing lights, and the appearance of a large, dark shadow across the visual field. Previous history of mild floaters. These are the findings. Vitreous body. A hyperechoic folded mobile membrane is observed within the vitreous chamber, suggestive of a vitreous or retinal membrane resulting from the retinal detachment process. This membrane exhibits mobility with eye movements, indicating it is not adherent to the posterior eye structures. Retina. The retina shows a clear detachment, typical of rhegmatogenous retinal detachment. The presence of a retinal break or tear is confirmed, facilitating the seepage of vitreous fluid into the subretinal space, exacerbating the detachment. Choroid and sclera. These structures are unremarkable with no evidence of detachment or significant pathology. Optic nerve, normal in appearance without any signs of edema or abnormal enlargement of the optic nerve sheath. This is the impression. The ultrasound findings are consistent with a Rhegmatogenous retinal detachment, complicated by the presence of a hyperechoic folded mobile membrane within the vitreous chamber, likely representing detached vitreous or retinal tissue. This complex presentation suggests a significant pathological process within the vitreous and retinal structures. Now we have a report of posterior vitreous detachment, clinical indication, patient complaints of sudden onset of floaters and occasional flashing lights. No history of ocular trauma or previous retinal pathology. These are the findings. Vitreous body. Evidence of posterior vitreous detachment is observed, characterized by the presence of a distinct echogenic line anterior to the retina, representing the separated posterior hyaloid membrane. This membrane demonstrates mobility with eye movements, confirming its detachment from the retinal surface. Retina. The retina is intact and attached with no signs of tears or detachment. The interface between the detached vitreous and the retina is clear, with no adhesions or tractional abnormalities noted. Choroid and sclera are normal. The optic nerve appears normal in echogenicity and diameter, with no evidence of edema or other abnormalities. This is the impression. The ultrasound findings are indicative of posterior vitreous detachment with a clear separation of the posterior hyaloid membrane from the internal limiting membrane of the retina. No associated retinal tears or detachments are identified. The vitreous body shows the typical appearance of PVD without evidence of hemorrhage or other complications. This is a report of Vitreoretinal Traction, clinical indication, assessment of complex visual symptoms including flashes, floaters, and sudden visual field loss, history of diabetes mellitus, and previous episodes of mild vitreous hemorrhage. These are the findings. Vitreous body. Signs of posterior vitreous detachment are evident with a clear separation of the posterior vitreous hyaloid face from the retinal surface. Within the vitreous cavity, areas of lacuna are identified, indicating localized liquefaction or vitreous degeneration. Additionally, scattered echogenic foci consistent with vitreous hemorrhage are observed, contributing to the complex visual symptoms. Retina. Evidence of vitreoretinal traction is present, with the vitreous exerting mechanical pull on the retina, particularly at the site of posterior vitreous detachment. The traction is associated with localized retinal elevation, but no full thickness retinal detachment. The areas of traction coincide with regions of vitreous adhesion and partial vitreous liquefaction. The visualization of choroid, sclera, and the optic nerve is limited due to detached membranes and vitreous hemorrhage. Here is the impression. The ultrasound findings reveal a complex interplay of vitreoretinal traction, posterior vitreous detachment, lacuna within the vitreous cavity, and vitreous hemorrhage. These conditions collectively contribute to the patient's visual symptoms and represent a challenging diagnostic and management scenario. In the recommendations, you can advise referral to an ophthalmologist. OCT and fluorescein angiography can be advised as well. This is a report of proliferative vitreoretinopathy, clinical indication, assessment of the patient's visual decline and discomfort post-retinal detachment surgery with suspicion of proliferative vitreoretinopathy development based on clinical examination. Findings include presence of moderate echogenicity within the vitreous, indicating vitreous opacities that may be secondary to vitreous hemorrhage or cell infiltration associated with PVR. In the retina, there is evidence of epiretinal membrane formation leading to multifocal areas of retinal elevation and tractional retinal detachment. These membranes may appear as linear to slightly irregular echogenic structures on ultrasound, exerting traction on the retina and contributing to its detachment. The choroid, sclera, and optic nerve are normal. This is the impression. The ultrasound findings are consistent with proliferative vitreoretinopathy, characterized by the presence of epiretinal membranes causing multifocal tractional retinal detachments. This condition appears to be advanced with significant involvement of the vitreoretinal interface and consequent retinal structural changes. These are the recommendations. Urgent referral to an ophthalmologist is recommended for further assessment and consideration of therapeutic interventions. This is a case of exudative retinal detachment. Clinical indication is decreased vision in the right eye, recent diagnosis of hypertension. These are the findings in the right eye. The vitreous cavity has some echoes indicating vitreous hemorrhage. The retina is observed to be detached with a notable accumulation of subretinal fluid consistent with an exudative retinal detachment. The detachment extends from the optic nerve head to the periphery, sparing the foveal region. No retinal tears or breaks were identified. There is evidence of choroidal thickening, suggesting potential underlying causes such as inflammation or vascular abnormalities that may have contributed to the exudative process. The optic nerve head appears elevated, which may be associated with the observed retinal detachment. No abnormalities were detected in the sclera and orbit. This is the impression. The ultrasound findings are indicative of an exudative retinal detachment in the right eye, characterized by significant subretinal fluid accumulation, vitreous hemorrhage, and choroidal thickening. The absence of retinal tears suggests a non-rhegmatogenous process. Given the patient's recent diagnosis of hypertension, it is possible that hypertensive retinopathy with choroidal effusion could be contributing to the exudative detachment. Further evaluation with fluorescein angiography and consultation with a retinal specialist are recommended for comprehensive management and to address potential underlying systemic conditions. This is a report of choroidal detachment, clinical indication, persistent eye pain, and visual disturbance in the right eye, history of hypertension. These are the findings in the right eye. Choroid. The examination revealed a choroidal detachment characterized by two distinct convex-shaped hyperechoic bands within the choroidal space. The bands demonstrate internal vascularity on Doppler imaging. The bands maintain a fixed position relative to eye movements, suggesting a solid or semi-solid composition rather than purely fluid. The optic nerve, sclera, and orbit are normal. This is the impression. The ultrasound findings suggest a complex choroidal detachment in the right eye with the presence of two convex-shaped hyperechoic bands exhibiting internal vascularity as demonstrated on Doppler imaging. The characteristics of these bands may indicate choroidal hemangioma or similar vascular lesions within the choroidal space, contributing to the detachment. The fixed position of these bands suggests they are not freely mobile fluid collections. Given the patient's history and nature of the findings, further evaluation with indocyanine green angiography and MRI of the orbit may be warranted to further characterize these lesions and guide management decisions. This report is of choroidal hemorrhage, clinical indication, acute onset of pain and vision loss in the right eye following cataract surgery. Here are the findings. In the vitreous cavity, there are diffuse, low to medium reflectivity echoes suggesting the presence of vitreous hemorrhage. The retina appears attached throughout with no evidence of retinal detachment or tears. There is a large echogenic dome-shaped mass in the posterior segment consistent with a choroidal hemorrhage. The mass exhibits heterogeneous internal echoes indicative of fresh and clotted blood. The hemorrhage is most prominent temporally and extends towards the macula with an approximate maximal thickness of 6 mm. The optic nerve head is obscured by the echogenic mass with no clear signs of optic nerve head drusen or swelling visible through the hemorrhage. There is no evidence of scleral rupture or orbital fractures. The extraocular muscles appear normal in size and echo texture. This is the impression. The ultrasound findings are highly suggestive of a significant choroidal hemorrhage in the right eye, likely secondary to recent intraocular surgery. The presence of vitreous hemorrhage is also noted, which may be secondary to the same traumatic event. The extent of the hemorrhage, involving the temporal choroid and extending towards the macula, raises concerns for potential long-term visual impairment. Recommendations include referral to an ophthalmologist and consideration for surgical interventions. Here is an ultrasound report of Tractional retinal detachment. Clinical indication is decreased vision and floaters in the right eye, history of diabetes mellitus. Here are the findings in the right eye. Vitreous cavity. There are moderate echogenic opacities within the vitreous, suggesting vitreous hemorrhage or floaters. A section of the retina is elevated from the underlying choroid, consistent with a retinal detachment. This detachment appears to be tractional in nature, with echogenic membranes extending from the retina to the vitreous cavity. indicating proliferative vitreoretinopathy or neovascularization as the underlying cause. Retinal detachment characteristics. The detachment is observed primarily in the superior quadrant with an irregular surface suggestive of tractional forces at play rather than Rhegmatogenous, that is, tear-related detachment. The other eye structures were normal. This is the impression. The ultrasound findings suggest a tractional retinal detachment in the right eye, likely secondary to proliferative diabetic retinopathy, evidenced by the presence of echogenic proliferative membranes and vitreous hemorrhage. This type of detachment is caused by fibrovascular tissue contraction, pulling the retina from its underlying layer. Recommendations include urgent referral to a vitreoretinal specialist for detailed examination and consideration of surgical intervention. This is a report of retinoschisis, clinical indication, blurry vision and shadows in the peripheral vision of the left eye. These are the findings. Vitreous cavity has some echogenic areas. There is evidence of an abnormal separation within the retinal layers consistent with retinoschisis. The area of separation appears as a smooth, dome-shaped elevation in the outer plexiform layer. There is evidence of retinal detachment. No other abnormalities were detected. This is the impression. The ultrasound findings are indicative of retinoschisis in the left eye, characterized by the splitting of retinal layers with presence of non-rhegmatogenous retinal detachment. Regular follow-up with an ophthalmologist is recommended. This is a case of optic disc Drusen. These are the findings in the right eye. The vitreous cavity is clear. The retina is flat and normal. The optic disc shows hyperreflective foci with acoustic shadowing, consistent with the presence of optic disc drusen. The choroid and sclera were normal. The left eye had similar findings, with hyperechoic foci indicative of optic disc drusen. The findings suggest bilateral optic disc drusen. This is the impression. The ultrasound findings in both eyes are indicative of bilateral optic disc drusen, characterized by hyperreflective foci with subsequent acoustic shadowing at the optic discs. The condition is most likely congenital and not acquired, given the patient's age and bilateral presentation. Regular ophthalmologic follow-up is recommended to monitor for any changes in visual field or optic nerve function. This is a report of persistent hyperplastic primary vitreous. Clinical indication: leukocoria noted in the left eye. Concern for intraocular pathology. Leukocoria refers to a white pupil. These are the findings in the left eye. Vitreous cavity. There is presence of a dense echogenic structure within the vitreous cavity, consistent with the persistence of fetal vascular tissue characteristic of PHPV. This structure appears to extend from the optic disc towards the lens, indicating the remnant of the hyaloid artery. This patient is a child. The lens shows irregularity and posterior displacement, suggestive of posterior lenticonus, commonly associated with PHPV. There are no clear signs of cataract formation at this time. The retina is attached and shows no signs of detachment. However, there is evidence of traction on the retina from the fibrovascular tissue extending into the vitreous, raising concern for potential future retinal detachment. The optic disc appears elevated and is partially obscured by the echogenic fibrovascular tissue, suggesting traction and possible optic nerve involvement. The choroid and sclera are normal. This is the impression. The ultrasound findings are highly suggestive of persistent hyperplastic primary vitreous in the left eye, characterized by the presence of echogenic fibrovascular tissue within the vitreous cavity, posterior lens changes, and optic disc involvement. These findings are consistent with the clinical presentation of leukocoria and warrant further evaluation and management. Now we have a case of asteroid hyalosis. Clinical indication: evaluation of floaters in the right eye, difficulty in fundus examination due to vitreous opacities. These are the findings. Vitreous cavity shows numerous small, highly reflective echoes scattered throughout, consistent with asteroid hyalosis. These particles exhibit no acoustic shadowing, indicating their small size and diffuse distribution. The retina appears detached and normal in contour. Detailed assessment of the retinal surface is somewhat obscured by the dense vitreous opacities. The optic disc and nerve head appear normal. However, visualization is partially hampered by the vitreous opacities. No evidence of optic disc drusen or swelling. The choroid and sclera are normal. This is the impression. The ultrasound findings are consistent with asteroid hyalosis in the right eye, characterized by numerous small reflective particles within the vitreous cavity. This condition is typically benign and does not adversely affect the structural integrity of the retina or optic nerve, although it can complicate fundoscopic examination. A follow-up with an ophthalmologist is advised. This is a case of choroidal melanoma. Clinical indication: visual disturbances and a shadow in the field of vision of the right eye. These are the findings. The vitreous cavity is normal. The retina is partially detached with the detachment observed in the superior quadrant. The detached retina appears to be elevated anteriorly from the underlying choroid, consistent with serous retinal detachment. In the choroid, there is a dome-shaped echogenic mass within the choroidal layer, located posteriorly near the macula, measuring approximately 12 mm in largest basal diameter and 6 mm in thickness. This mass exhibits low to medium internal reflectivity, characteristic of choroidal melanoma. The optic nerve appears uninvolved by the mass. However, detailed assessment is limited due to the choroidal mass. No extraocular extension of the mass is observed. This is the impression. The ultrasound findings are consistent with a diagnosis of choroidal melanoma in the right eye, with a significant lesion located posteriorly near the macula. Associated complications include serous retinal detachment in the superior quadrant, likely secondary to the mass effect, and local inflammatory response induced by the tumor. The absence of vitreous opacities and extraocular extension is noted. However, the presence of retinal detachment necessitates urgent attention. Recommendations include immediate referral to an ocular oncologist. Further diagnostic imaging is advised. This is a case of ciliary melanoma. Clinical indication: pain and blurred vision in the left eye. These are the findings. There is evidence of vitreous hemorrhage. Retina is attached and normal in appearance. Ciliary body. There is a solid dome-shaped mass arising from the ciliary body, exhibiting medium to high internal reflectivity. The mass measures approximately 7 millimeters in base diameter and 4 millimeters in thickness. This lesion demonstrates characteristics suggestive of a ciliary body melanoma, including its solid nature and localized vascularity as evidenced by Doppler flow analysis. Lens: no direct involvement of the lens or evidence of cataract formation. However, there is slight anterior displacement of the lens, likely due to the mass effect from the ciliary body lesion. The optic nerve is normal and there is no extraocular extension. This is the impression. The ultrasound findings are suggestive of a ciliary body melanoma in the left eye, characterized by a solid dome-shaped mass with medium to high internal reflectivity originating from the ciliary body. The lesion's impact on the adjacent lens and potential for growth necessitate further evaluation and management. There is evidence of vitreous hemorrhage. Immediate referral to an ocular oncologist is recommended. This is a report of Osseous Choristoma. Clinical indication: unexplained visual disturbances and a mass detected during routine ophthalmic examination in the right eye. These are the findings. The vitreous cavity is clear. Choroid: there is a well-defined, highly echogenic mass within the choroidal layer, measuring approximately 5 millimeters in largest basal diameter and 3 millimeters in thickness. This mass exhibits acoustic shadowing consistent with the presence of calcification or ossification typical of an osseous choristoma. The lesion does not demonstrate any vascularity on Doppler imaging, supporting its non-vascular nature. Visualization of retina is limited due to the calcified osseous choristoma. The visualization of optic nerve is also limited. There is no evidence of extraocular extension. Here is the impression. The findings are suggestive of an osseous choristoma in the right eye, characterized by a well-defined, highly echogenic mass within the choroid with significant acoustic shadowing, indicative of ossification. This benign lesion is uncommon and typically does not affect vision unless it impacts adjacent ocular structures. Regular ophthalmic follow-up is recommended. This is a case of retinoblastoma. The patient's age is 3 years. Clinical indication is leukocoria and strabismus, which is malalignment of the eyes, is noted in the right eye during pediatric examination. These are the findings. Vitreous cavity. There are scattered medium to high reflectivity echoes within the vitreous cavity, suggestive of vitreous seeding. Retina. A large mass is observed arising from the retina, occupying a significant portion of the posterior segment. This mass demonstrates mixed internal echogenicity with areas of calcification characteristic of retinoblastoma. The optic nerve appears normal in diameter, but assessment for possible tumor invasion is limited due to shadowing from the mass. The shadowing is not shown in these images, it is at a different level. Further evaluation with MRI is recommended. No choroidal lesions were noted. The mass appears confined to the retinal layer with no evidence of choroidal invasion at this time. And there is no evidence of extraocular extension. However, detailed assessment is limited due to the size of the intraocular mass. This is the impression. The ultrasound findings are highly suggestive of retinoblastoma in the right eye, characterized by a large retinal mass with internal calcifications and evidence of vitreous seeding. The presence of such a tumor in a child presenting with leukocoria and strabismus is consistent with the clinical suspicion of retinoblastoma. Immediate referral to a pediatric ocular oncologist is critical for further evaluation and management. This is a report of Phthisis Bulbi, clinical indication, assessment of the left eye for suspected ocular degeneration and calcification following a history of chronic inflammation and previous ocular surgery. These are the findings in the left eye. Vitreous cavity. The vitreous cavity displays multiple highly reflective echogenic foci consistent with vitreous calcifications. The retina appears to be attached but is difficult to evaluate comprehensively due to the extensive echogenic foci in the vitreous and underlying choroidal calcification. Choroid, there is evidence of generalized thickening and increased echogenicity with areas of pronounced acoustic shadowing indicative of choroidal calcification. This finding is consistent with long-standing changes associated with Phthisis bulbi. Globe. The overall size of the globe is reduced with scleral thickening and increased echogenicity, characteristic of the atrophic changes seen in Phthisis bulbi. The anterior chamber is shallow and the lens position or integrity could not be adequately assessed due to the extensive intraocular changes. The optic nerve appears atrophic with increased echogenicity and cupping. Clear visualization is compromised by the posterior shadowing from the calcified choroid. This is the impression. The ultrasound findings are indicative of Phthisis bulbi in the left eye, with significant intraocular changes including vitreous calcifications and choroidal calcification. These findings suggest an advanced stage of ocular degeneration, likely secondary to chronic inflammation, previous trauma, or surgery. The extent of calcification and atrophy indicates a long-standing process. Now we have a report of ocular foreign body, clinical indication, suspected metallic foreign body in the right eye following a metalworking accident. These are the findings. There is presence of a highly reflective echogenic focus within the vitreous cavity, measuring approximately 2 millimeters in its largest dimension. The retina adjacent to the foreign body shows a localized area of elevation suggesting a potential impact site or associated retinal detachment. Further evaluation is necessary to assess the full extent of retinal involvement. Choroid and sclera. No evidence of penetration through the sclera is observed in the vicinity of the foreign body. The choroid appears intact but requires further evaluation to rule out any underlying damage. The optic nerve appears unaffected by the presence of the foreign body with no signs of trauma or swelling. Anterior segment. Detailed examination of the anterior segment was not the focus of this ultrasound. However, no anterior chamber foreign bodies were noted in the available views. This is the impression. The ultrasound findings are consistent with the presence of a foreign body within the vitreous cavity of the right eye, accompanied by a localized retinal elevation suggestive of an impact site or early retinal detachment. The absence of scleral penetration in the ultrasound field of view is noted, but careful examination is required to assess for any full thickness injuries. Immediate referral to an ophthalmologist specializing in vitreoretinal surgery is recommended for further evaluation and management. This is a report of globe rupture, clinical indication, severe eye trauma after a workplace accident, suspicion of globe rupture. Here are the findings. The vitreous cavity contains diffuse, low to medium reflectivity echoes, indicative of hemorrhage. No clear view of the posterior vitreous due to the disrupted anterior segment. Anterior chamber appears collapsed, with echogenic material present, likely representing hemorrhage and inflammatory debris. There is evidence of an irregular scleral contour with a localized area of discontinuity consistent with a scleral rupture. Adjacent to this area, there is scleral thickening and an inward curvature suggestive of scleral buckling. Retina. Evaluation of the retina is limited due to the anterior segment disruption and vitreous hemorrhage. However, there are no clear signs of retinal detachment in the visible areas. The lens cannot be clearly delineated, suggesting possible dislocation or cataract formation secondary to the trauma. The optic nerve appears intact, but evaluation is somewhat limited due to the compromised state of the globe. This is the impression. The ultrasound findings are consistent with a globe rupture of the right eye, characterized by a collapsed anterior chamber, scleral discontinuity indicating rupture, and scleral buckling. These findings are indicative of significant ocular trauma with potential for extensive intraocular damage. Immediate referral to an ophthalmologist specializing in ocular trauma is recommended for urgent assessment and intervention. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.